of, sort of national security. And all of these things need to mature in order for us to get to the sort of, AI age, the cognitive age, if you like. Because unless the data is engineered well and it's secured, we're not going to be able to leverage these things for the future. So really, a global understanding around the steps we need to take and in which order is very much needed. And the AI space, that's still emerging in terms of its regulation, its standards, and all of those things. We're not ready yet to take this at scale and pace. There still needs an awful lot of work, but we do have time to get our data ready for it to be used upon. And so data readiness is a major topic that I think we're all going to be talking about in the coming years. What does data that is for AI look like? How do we get the skills to ensure that we have people that are able to actually make that journey? How do we actually meet citizens' needs when it comes to data, both for things like, shared records, so things like the European Health Data Space, and how do we make sure that citizens have transparency in how their data is being used? That's a big area that needs to be explored and worked through. So I very much do believe that, we need to engage with AI. We need to explore what it means. But this whole journey is going to take us a number of years as a set of professions globally. And that journey will need standards bodies, policymakers, those working in digital health to all collaborate and ensure that we are working on standards together. And I know that India and Europe are very much engaged in, that standard space and in dialogue about how we take this journey together. But I think what's really important, and what we found from our first policy forum at the International Policy Forum at MedInfo in Sydney, was globally and not replicate across different nations. And those things do include standards for data. They do include best practices. They do include standards for cybersecurity and data security as well. And so as we sort of explore this landscape and moving forward, I think it's going to be really interesting to see what, discussions are had at the Europe-India Digital Health Week and how they reflect this and how they reflect what is the coming horizon for healthcare. We have to also acknowledge as well that most healthcare systems globally are not sustainable unless we start using digital and data and AI in the future to actually ease the burden on those systems. And easing the burden means things like automation, it means decision-making, it means management by exception rather than seeing every patient. It means empowering patients with information and, sort of things like risk stratification so they can make decisions. And those new sort of tool sets for the sort of sustainable healthcare system of the future are going to have to be formed by the digital health profession with those standards supporting. So it is essential we do take the journey, but taking the journey too rapidly or without all of the things we need in place is a really unwise idea. And so while I'm very pro AI and while I'm very pro the progress we need to make, I'm pro actually, forming sandboxes, working out what is needed, working out how we move forward together. And actually, we've got a regulatory sandbox that's actually happening here in the UK at the moment around AI. And that is going to look both at generative AI and traditional AI models. And it's being run by the MHRA. And it's really just to consider what the parameters are that we need to take into account for our future governance and our future regimes. One thing I've done a lot of work on is lifecycle management for AI, and we're not ready for it yet. That's where we look at things like clinical safety, we look at governance, we look at the performance of the AI, we look at bias, and we create an oversight system that can look at all of the sort of AI tools that are being used in an enterprise, a health enterprise, to monitor real time their safety and report on their safety. These tools don't exist yet. They're not out there, but we have sort of conceptual frameworks of how they will work in the future. And again, those need to be worked through with different healthcare systems to ensure that we have the tool sets to allow us to operate AI safely. So overall, AI is going to be part of our future, but we have a saying in the UK, more haste, less speed. If we go too fast, we will do things wrong, it will break, and we will have lost confidence. If we do this in the right order and at the right pace, considering data very carefully as the main enabler for AI, we can make the right pace of progress, which in turn will make sure that we have a tool set that will allow us to enable the sustainability of healthcare systems. Finally, I hope you really do enjoy Digital Health Week. If you want to tweet or comment on this, my Twitter handle is @UKPenguin. I'd really welcome any feedback and welcome any contact from people who are on this journey with me. But I know we're all hugely enthusiastic about the future. I just think that we need to take stock of everything before we move forward. And I do think we will have a good future in the sort of data and AI space if we take the journey at the right pace. So thank you very much and enjoy your week.
So thank you, Professor Dunscombe, for this wonderful introduction. And I really think it set us up for a very nice conversation that follows. We are now moving forward to our panel. And once again, thank you so much for the panelists who are with us today. So I will be doing a brief round of introductions, and then we will move on to our moderator, who will take over the conversation. So we have, and by an order of an alphabetical order, we have with us Professor Jamal Hashem, coming from the Medical University of Bahrain. We have with us Dr. Maaz Shaikh, Vice President and responsible for project management at M42 Health. We have with us also Professor Saleem Sayani, Director of Technology Innovation Support Center at Aga Khan University in Pakistan, and Dr. Samane Kuchaki, Senior Lecturer in Machine Learning for Healthcare at the University of Surrey. With us and moderating, we have Professor Tiago Tavares Gomes, founder and CEO at Sigil Scientific Enterprises and a professor at the Faculty of Medicine of Porto. So, and welcome all, and I hope you have a very nice conversation ahead.
Thank you very much, Sophia, and good morning, everybody, or good afternoon. This is a very widespread session across time zones, so that's a great thing. It's a real pleasure to be here and an honor to discuss these very crucial topics. And I think that everyone here in the panel will have opinion and insight to share after this inspiring vision of Dr. Rachel. So before we delve into the actual topics that we have prepared for discussion and that I will actually share here on the Zoom chat, because it will be probably useful also for the colleagues to have in mind. I think it would be very nice to hear your thoughts in an unconstrained way and understand the perspective that each one of us is coming from, because it's not only different geographies, it's also different professional backgrounds and different ways of contributing in this road we're taking. And so I believe we'll benefit a lot from that in particular. Just for some additional context, I am a family physician and a software engineer. I've been doing all my life in trying to bring better and better quality of care through digital health. And so I'm extremely interested in these topics and created this as my own personal mission, quite frankly. And we'll be very interested to hear about your thoughts. And without any further ado, I will probably follow the order of the little Zoom rectangles, if you don't mind. And so I, in first place, pass the word to Professor Samane to hear what's your take in this field, and what's your broad perspective on this. Thank you.
Thank you. I'll start just with a brief description, like introduction of me. I am currently a senior lecturer at University of Surrey. Most of my research focus is on adapting advanced machine learning approaches for healthcare applications, including integrating of existing clinical and biological knowledge in learning. I really believe that we should understand the problem and then see how we can adapt the techniques that exist for a better performance and for something that makes sense. I'll start with some statistics about like dementia. While I know that it is more general discussion, but I just want to start with something to show that the research gaps that exist. And like especially in the care planning and also data analysis in terms of the machine learning that comes into the picture. Dementia, like people who face with dementia usually spend 100,000 on their care. Some of them might even spend much more. A large portion of the care and the money that we spend in care costs in the UK is related to dementia, and they usually need to, their care is much more expensive. And there is one issue is that some of their hospital admissions usually can be avoided if we help them and if we understand the health deterioration earlier. One main point for most of these people, according to Alzheimer's Society, is that they prefer to live in their home as long as possible. But the issue is that it is a long-term condition. They might experience episodes of health-related issues such as infections, agitations, wandering. And the first time that they end up in the hospital, the suggestion might be to move them to care homes. But even if we can delay these move to care home for a few months, it can save a lot of cost, and also it is, it helps with their progression of the disease and for their families and everything. But what is the problem currently is that when they go to a memory clinic or social services for planning, everything is usually based on limited data. It's based on a few tests, and also everything depends on their care at that and their health at that time, and their sleep patterns and everything that happened in the nights before that sort of conversation with healthcare providers. And even if healthcare providers wants to access the data that is available across the healthcare records and other data which is available for the person, it is usually very time consuming and it is not easy easily interpretable for them, because they have to load data across multiple fragmented systems, and interpreting them usually is not very easy either. This is one challenge. But even before the diagnosis, if we face, for example, with older population with lots of comorbidities, again, understanding that what is the main cause and helping them for an earlier diagnosis is usually not possible, because even they might not properly report the symptoms for different reasons, or because of a very short time period that they can spend with the healthcare providers. And here that machine learning comes to the picture, because for example, we have now access to electronic records that shows the care pathway for people across many years. Then there are initiatives such as UK Biobank, or like integrated care system in some of the trusts, such as Northwest London, that we can integrate across multiple data sources and develop machine learning approaches that can analyze this sort of data, provide some insight into the data, and provide visualization and interpretations that makes it easier to integrate the data across multiple sources. For example, our team at the UK Dementia Research Institute developed an in-home monitoring system to continuously monitor people and understand if there is episodes of health-related issues. That is very interesting, but then the data is super noisy because we don't want to have impact on day-to-day life. Then the question is that how we can develop machine learning approaches that can deal with such problems, such as high dimensionality, variations in granularity, like patterns changes, missing data, and a lot of other issues that comes with these problems. And that is where I look at machine learning approaches. For example, one of my research interests is around self-supervised learning and representation learning, into how we can look at the data differently. If we have sensors, can we build a graph learning approach without the need with a lot of labeled data? If the data has missing data, can we integrate the clinical knowledge into the imputation of the data? If we have clinical notes like text on a structured data and structured data, how we can integrate them. And for these machine learning approaches, because one issue is the computational cost as well, can we make them more computationally appealing, less expensive, while we don't compromise on performance of these approaches? And then can we reach to a point that we can first help people for a better diagnosis of especially long-term conditions, a better population screening? And then when they are diagnosed, because at this stage for several, like especially neurodegeneration conditions, they are left with not a proper personalized planning. Can we do machine learning based on the available data, and then reach to a point that we can help them across their care journey as well, to save cost, to improve outcome, and to help, everyone, clinical team, and the people who are involved, the families. But at the same time, because we are engineers, I feel that this should be a collaboration between like a multidisciplinary team. And that is one of my always aims and interests, which I think that we should learn the problem. We should understand that these tools are used not by us, with some other people, and then integrate views from different people, like from people who are going to use it into our system, which was always one of my interests. And that's why I feel that, I mean, developing machine learning is the easiest part in healthcare applications. Always understanding the data, proper pre-processing and validating, and building a tool that can be used in real practice are the main challenges. Thank you.
Thank you very much, Professor Samane, for very insightful sharing. I could not agree more with all the things you said, and you touched a very especially important point with your example on dementia and chronic diseases, the need for all this integration, not only data, but also capabilities of the different people. If in the end we cannot reach the clinical impact, then what was the purpose of all of this, right? So thank you so much. I would like to comment a lot more, but I will pass the word to Professor Saleem, following the order of the little rectangles in Zoom. Professor, please.
Thank you so much. So I agree wholeheartedly with what was just said. So little background about myself, and then I'll talk about what we are doing in terms of making sure the data is reliable before we get into AI. So as a background, I am a technologist. So I am a doctor, PhD in technology and innovations management. So that is what I do. And I work with multidisciplinary teams here within the AKU network and Aga Khan Development Network as a whole, which is in 30 countries. And we have different segments, and healthcare is one of them. And that is my area of focus. Now, coming to data and AI, it's a long debate. And it is very simple to me. Simple in the sense that you cannot have AI without having a good data set, because data set is a vehicle on which AI actually runs. So we got to make sure that we have a good foundation first in place so that we can have a good building that we can build upon that foundation. So there are so many areas that I can talk about when it comes to AI and in data. Foundation for AI success is what? Data. Data is, AI is as good as data. So garbage in, garbage out, we all know that, right? The data is standards, and then the consistency that data brings to AI algorithms. Governance, when it comes to data governance, that is so important. And in building algorithms in AI, if you need to have a good sound foundation in terms of data governance and also in terms of policy, data policy, right? So that is important. But I'll just pick one area that is really close to my heart, and that I believe is the foundation of data and moving forward. If AI algorithm would be a successful algorithm or not, that is only, it boils down to one area, and that is reducing the bias in the data. So if you reduce the bias in data, and that is what we work on, we try to reduce bias in the data set, because if we are using this data set as a tool to develop a predictive analysis or predictive algorithm, then we got to make sure, this is so important, we got to make sure that we reduce bias in this data set, because if we don't, then guess what happens? We have a predictive analysis or predictive algorithm that is biased to start with, right? So it defeats the purpose, the whole purpose of having an algorithm. So that is really important, and that is what we are working on within the network with the huge data sets that we have. And as you can imagine, with a health system as big as Aga Khan Development Network, with primary care, tertiary care, and secondary care and tertiary care hospitals, we have huge data set. What we need to do is that we need to clean this data so that there's no bias in the data. So when we use this to build an AI algorithm, we are sure that we are getting a predictive algorithm that is very meaningful, right? Now, something that is very important for us. And then when I say us, I say for people in South, that we are fortunate that we can actually have large amounts of data, and we can do so much with so little overhead, so to speak. So that is a gold mine that we all sit on. We got to make sure that we utilize it properly. And this is the time. We are in that golden era of time where we have resources. We are sitting on this gold mine of data. We need to use it right. We need to make sure that the data is, again, unbiased and also clean so that it can provide you better results, right? So that is what we are working on, and that is what I am sure everyone in Deep South, we all are working on, and also people like yourselves in Europe and in North America, you are also working on. Unfortunately, you may not have that much leverage or freedom that we do in our countries, respective countries. So again, we are sitting on a gold mine, and we need to use it right. This is the time. This is perhaps the only chance that we have, that rather than running after AI, we should make sure that we have good foundation in terms of data. And this topic of today's discussion is so right and so fitting, data first, AI later, because that is exactly what the theme is, and that is what exactly the future is. We need to make sure that we capitalize on this, because if we do it wrong, our future generation will not forgive us. So I think that is what I feel, that is what I believe, and back to you.
Thank you so much, Professor Saleem. I also totally agree with what you say. And, bias in healthcare data, particularly if you talk about electronic healthcare data, that is the given. And the thing I find extremely interesting about this bias is that it's mostly a non-stationary process. So the bias, the sampling, if you think about the distributions, the latent distribution that govern that bias, they change across time in ways that we actually do not know. So if you do not account for that, well, it's really hard to try and create any AI or any clinically meaningful decision that will not be mostly just an artifact of how healthcare was at a given point in time, at a given place, more than the actual clinical effect. Maybe if we talk about the sensors and other kinds of data sources, the bias by default will be minimized. But the bulk of electronic health records, which also in my view is the gold mine that I would say many countries we are currently having, indeed is biased by default. So it's very interesting to understand exactly that you are doing so much work on that direction, and I have this very critical concern, because I also share with that same passion and need to do further work in that regard.
If I may, just
please
build on that there are two types of biases, as we all know: explicit bias and implicit bias. So it is very easy for us to point out explicit bias, but it is so difficult for us to identify and address implicit bias, right? And this is where the challenge comes. And I believe that we globally, we need some sort of a standard by which we can provide some sort of guidance to everyone else who is working in this area, so that we don't have to reinvent the wheel, and we have some sort of an advisory body, global body, where we can work together and provide some sort of guidance to others who are on this journey together.
I absolutely agree with that idea, and I hope we will be able to build upon that later on the session on the topics we have. Thank you so much, Professor Saleem. And now the next little square is of Dr. Jamal Hashem. Very nice to meet you, and I pass the word to you.
All right, thank you. Thanks so much, Tiago. And thanks for the invite, and thanks to everyone who's spoken already. So I want to touch on Dr. Samane's point about data reliability and the location of care when AI becomes fully integrated into clinical practice. So as you mentioned, for dementia patients and for the patients that I deal with, diabetic foot patients and peripheral arterial disease patients, their preference is to receive care at their home. And there's an added advantage to that, especially when it comes to diabetic feet, is that it's safer from a nosocomial infection point of view. We wouldn't be seeing all these multi-drug resistant bacteria in people's wounds if people were receiving more consistent care at their home, which is something that clinical integration of AI can absolutely provide, or promises to provide. Now back to where it all stems from, which is the data, and everyone's made very valid points about the fact that the data that we have needs a lot of cleaning. It needs different ways and different perspectives to look at this data in order to really make the most of it and to get real insights. Now, some of the barriers to accessing data are different across different countries, as Professor Saleem said. And I'm going to make a bit of a controversial point. I totally despise the GDPR, right? I think we can all agree that data privacy protection is very important, and it's very important that patients have ownership of their data. However, I feel that the GDPR is a bit of an overcorrection. I feel that it's steered to the other side, and that it can stifle innovation if it's very difficult to do an audit of your own practice if you follow the strict rule of the law. So I think that an overhaul of data privacy protection regulations with a view to how it can support innovation while maintaining patient and anonymity is a very important step if we are to really reach the potential of machine learning and deep learning clinical applications. One idea is if you look at Sweden and their organ donation system, they have an opt-in instead of an opt-out system, and that was introduced years ago, and that led to a huge uptake and a huge number of people registering as organ donors, because instead of signing to say I want to become an organ donor, you sign to say, oh, I don't want to become an organ donor. And so simple measures like creating an opt-in system where patients who are admitted to the hospital or patients who come to a clinic visit can sort of have the risks and benefits explained to them, and then opt in for their data to be utilized for developing machine learning and deep learning applications that benefit them and similar patients. That's one way to do this. Now, of course, you'll run into the wall of, you can't store patients' data for more than 5 years or this or that, or you can't, unless you have an explicit reason to store patients' data, then you can't store it. I mean, to me, that's, again, another one of those things that stifles innovation, right? Because, you might be considering a clinical problem, pondering on a clinical problem, and, don't have access to the data to sort of fiddle around with it, see if it's a valid idea or if it's not. But if you have a sort of opt-in system, if you have a longer data retention time, then that again can truly support innovation. Now, the other sort of the flip side of this coin is, how do we protect this data, right? Because I'm sure we can all, I know there are multiple people working on this at the moment. If you consider an app that creates a completely automatable system for delivering insulin to children with type 1 diabetes, by looking at what they eat, their age, their BMI, et cetera, and all these factors, and connecting this app to an insulin pump, right? Now, that sounds like a fantastic idea because children are notoriously bad at managing, their type 1 diabetes unless they have a lot of education, a lot of intelligence, and a lot of familiar supervision. But now imagine that someone goes in and hacks the underlying algorithm. Now you're talking about, 100,000 kids receiving the wrong dose of insulin, instead of, if one physician makes a mistake with one patient, then you're talking about, one patient. I'm not saying that, one person's life is less important than 100,000, but, the impact will definitely reverberates more loudly if it impacts 100,000 people than it impacts one. So the question is, how far do we want to take this? There are 5 levels of automation, as I'm sure everyone here is aware of. Do we really want to go all the way to level 5, or are the risks of maximum fully automatable AI clinical systems, do they outweigh the benefits? I think yes. And I'm curious to hear what other people's views are on this. But the bottom line when it comes to data is we need to have more lax regulations and more innovative approaches to be able to access more data and to look at it in a different way. And that might require, the electronic health record system. Yes, it's had a lot of benefits, but I feel like every physician here and elsewhere will agree that it is the bane of their existence. You end up spending more time on it than you do with patients. And so, if we can hit 2 birds with 1 stone, overhaul the electronic health record system so that it allows you to spend less time on it, but at the same time stores data in a way that makes it more and more usable by machine learning researchers and data scientists. So yeah, that's pretty much it. Back to you, Tiago.
Thank you very much, Jamal. Great steering up of the debate, which is awesome. I understand that regulatory perspective can make things work at the pace that's slower than the full potential of what we could have right now. And particularly here in Europe, we are very proficient in creating regulation at a faster pace than the innovation. And I think we are in an interesting time where we need to take all these issues of the cybersecurity, the privacy, the machine learning, the data access to a bigger forum, not only in the technology perspective of how do you can process the data in a way that's privacy preserving, with more and more mechanisms coming into play, particularly with the European health data space, the homomorphic encryptions, federated learning, algorithm goes to data. There are so many avenues of work that are flourishing. But also, as you were mentioning, actually we as citizens view what is our perspective to that kind of data use for the sake of the quality of care. And I think the point you made, that rolling out algorithms that may be in a way potentially flawed or may introduce systematic error that could be avoided by broader ability to access data, that is a very compelling point when we think about pushing all the things into the clinic, and then even doctors start to question what will be left for me to do at the point of care with all this ChatGPT stuff rolling in. So I think that puts us in a very nice place to start touching here the topics that I believe I've already covered a bit, but here take a second round here on the panel and potentially start with this policy and ethics approach, as you already put that very straight on the table. I'd like to hear, and we have different geographies again, different cultures, different backgrounds here on the panel. How do you see that policy and regulation and ethics play a role in this regard of allowing AI to be both very accessible, to be created with maximal exposure to the available data, and also in regards to the security of how should it be deployed in the clinical setting, and also how can it be validated in your perspectives? Because as a clinician, and I trust that you feel this, if you look at the big number of publications that there are in AI in clinical setting, it's very hard to find any publications that go beyond an internal validation of the algorithms. It's very rare that you see actually algorithms being tested in an externally validation setting that actually shows that they really work. And I think the contrast is very stark when you compare, for example, with what you could call very primitive algorithms of machine learning, which are some of the classical calculations used in medicine every day, like the estimated glomerular filtration rate. That's a very basic machine learning on some kind of regression, but it is a machine learning in a basic way, and it is externally validated before you actually use that to do any kind of dose adjust of medications. Or if you think of spirometry outputs, which is amazing in my view, because what the output is percentage of predicted values. So the spirometry equations, they are very pretty much machine learning for decades, and they are externally validated worldwide before you actually use them. And they are questioned and they are upgraded. So we have this standard of things that we use, and they are very basic. They just give you a number. They don't decide anything, right? How do you see this comparison of classical medicine instruments that actually have been scrutinized and keep being scrutinized, and now all this new AI, which is way more powerful in potential? And how are we going to scrutinize it when the regulator even feel more and more complications on how to regulate on the algorithm that will train online across time? So if it works now, how do I know it will work properly later? So just to put here this into perspective, I will do a second round. And I think at this point we can be more interactive. If anyone wants to talk or just raise the hand so we can pass the word and get as much as collective discussion. But I will start again with Dr. Samane to hear your thoughts on this, and then do the round again, please.
I mean, I feel that surely ethics are in place to ensure safety of like patients and privacy and everything is, I mean, in the UK it's super regulated, you should know. And it takes sometimes, especially anything related to NHS might take at least 6 months of ethical process to get access to any data, which I still believe that it is for safety and everything. But the main issue comes when we have to develop the techniques on safe platforms that they have for the data access, which is okay to have a safe platform for data access. But the main issue is the computational power. And I mean, usually they are very old system, Windows, super slow. Even developing a basic machine learning approach there takes time and patience. And then when you want to do cross validation, it takes much more effort because, for example, if it is I remember during COVID, we were working on a project that was across a few hospitals with different electronic records. They wanted to do everything properly, but at the same time, very fast as well. I really don't know if it ended up with something meaningful because even making everything into one format for electronic records and validate it properly took a very, very long time. I don't know what would be the solution really, but I feel that if we could better, host like data hubs, for example, for DPUK, that they host a number of data sets, or better, moving toward a better integrated care data sets, and then data sharing in place that makes everything more clear and transparent for researchers. Because as you said, still most of the papers in healthcare either land on very small data sets, or even if they are on very large data sets, not properly reported or only internally validated. And I saw even moving from one hospital to another hospital can drop the performance very, very much in my experience. And I think that needs a bigger effort, like larger effort from like researchers. It needs initiatives that can make that possible. Thank you.
Thank you very much, Dr. Samane. Very insightful. When we see things changing from one hospital to the other, we question how big is the bias, like Professor Saleem was touching. So to you, Professor Saleem, what's your insight on this?
Yeah, so I agree completely with Samana, and that difference from one hospital to other hospital, and I'll just extend that there's a difference, huge difference when we go to from one country to other country as well. So based on my experience, that what we do is we work in Asia and Africa as well. So in Asia, we are in Pakistan, Afghanistan, Tajikistan, Kyrgyz Republic. In Africa, we are in Kenya, Tanzania, Uganda. So what I have seen based on my experience is that, there's, so we all know, and as Jamal talked about earlier, that policy is so rigid and it is so outdated. It is lagging behind innovation that we have. And there's a huge, very clear reason why that is the case. Because innovation is mostly driven by private sector and policy is public sector, right? So that's the huge difference. So we need to bridge that gap as leaders in this domain. I think that is our duty, that is our job, that we need to bridge this gap. And how can we do that? That's the question, right? So based on my experience in Pakistan, I'll just share this with you, that it only works when you partner with government, Ministry of Health or Department of Health in respective provinces or at a national level, and you make sure that they're part of this, whatever project, that data project you have or innovation project that you have, that is addressing healthcare needs of the people. Then Department of Health or Minister of Health has the ownership from day one. They are part of when you are conceptualizing the idea, when you're designing the idea, and also you are implementing this idea. The reason why we do that, or why we should do that, is because if we follow all that, then sustainability becomes a non-issue, because then it is sustained by the government. Because one of the challenges that we all face is that, hey, we have this grant, we have this funding, we implement a great idea, but once donor funding ends, then, project ends, right? And then people have no advocacy for it. Minister of Health has no advocacy for it because they were not part of it, right? So as this group, and we are fortunate that we have this group that is representing so many countries and so many regions, we should create awareness in government sector that why we need to have more relaxed policies or policies that match innovation, the speed of innovation, so that there would be a good balance. Otherwise, there's no point. We always will be struggling. And in Pakistan, actually, we are fortunate that I was able to do that with the Gilgit and Baltistan government and Khyber Pakhtunkhwa government with an innovation that we implemented. And guess what? Now they own it. And they changed their policy based on this one innovative project. So idea is that, if we make sure that government, public sector is part of our journey along with us, because they are going to sustain everything that we do, right? So that it will have some results. Otherwise, we always will be struggling, and we always will be saying, well, public sector is not at the speed that they should be, but they will never be at the speed at that should be if we don't hold their hand and we don't pull them with us. That is the challenge, and I think that is a challenge to all of us, and we should rise to that challenge. Thank you.
Yeah, Professor Saleem, amazing. I am feeling that I should have learned about all these initiatives in the countries you mentioned before, because it seems there are many lessons for us to learn as well, to port into what we're doing in Europe and in other regions as a path for success in this regard. So very, very, very interesting to learn about this this insight of how things could really work. And Dr. Jamal, you started this, you ignited this one, so back to you.
All right, thanks. So I have to say I totally agree with Professor Saleem and Dr. Samane on the importance of collaborating with the public sector, and that it truly is the only way forward. Here in Bahrain, the government actually has released its plan for integration of AI into all public and private sectors as part of their 2030 vision. And where there's a government organization here called Temkeen, and they just launched. This is an organization that supports small and medium sized enterprises, and they've just launched grants for private companies that are working on integrating AI solutions into their products. So the pace, as you said, Dr. Saleem, can be a bit slow, but things are happening, and they're moving in the right direction. Now, Dr. Simon had mentioned one thing, and Tiago, you commented on about the basically when the algorithm moves from one hospital to another, the outcomes change, and that could be due to bias. It could be due to the fact that we serve different patient populations when we work in different hospitals. But to me, it's a very interesting distinction between human physicians and the hypothetical AI physician in the future / current clinical AI applications. Because if I move from one hospital to another, unless obviously the equipment and the setting is very different, then my practice will stay the same. And again, like, this goes back to why I believe we shouldn't have fully automatable AI systems. Another reason why you might see drift down the line and with time is, let's say, for example, you've developed an algorithm for managing mild cases of asthma, fully automated it. Eventually, what will happen is you'll only see severe cases of asthma in the hospital. So the natural history of the disease, or the natural history of the disease that we're exposed to in the healthcare sector will change and evolve. So I don't believe that this is an avoidable issue. One solution that comes to mind is advanced AI agentic workflow that basically constantly tests and retests for model drift, and automatically tries to access new data, retrain, and so on. So the back end process, actually automating that might not be such a bad thing, as long as you have the right regulatory insight. But it then brings on another issue, which is I'm not trying to be controversial on purpose, Iago, but it's just it's just a difficult thing to talk about without, you know, bringing us some controversy, which is the issue of liability. You know, who's liable when the algorithm makes a mistake? At the moment, where, you know, in most domains, our intelligence still supersedes AI intelligence, then it's clear that we're reliable. But as things progress, right? Can you hold a 6-year-old child accountable for you know, their father or mother not driving right and getting into a car accident? You know, because that, you know, once we hit super intelligence, that's the kind of narrative that we're looking at. You know, one solution from the vaccine world, right, is to collectivize the risk. So what vaccine manufacturers in the US, as some of you may already know, what they do is they have a pooled fund which they all contribute to, and people who suffer adverse effects from vaccinations then can basically, when they, you know, when they sue a particular company, instead of the money coming from that company, it comes from this collective fund. But you know, but this just solves the monetary issue of liability. It doesn't come close to touching on patient outcomes and adverse patient outcomes and the quality of life that's lost, or years of life that are lost. So, you know, it's a very difficult one to say. And then let's say that, you know, I bring an algorithm with me from the hospital that I was working at to a new hospital, and now it's not performing as well. Is it am I liable for this, you know, or is the hospital that agreed to buy this you know, algorithm or this solution for their patients liable, or is it a collectivist sort of, you know, fund where no one is really liable but everyone is liable at the same time? Dr. Saleem, I see you got your hand up, and I'm very curious to hear what you guys say.
Yeah, Jamal, so you bring a very valid point. And, you know, what is really interesting here is that now what it means is that our discussion that we are having right now, it is not limited to just healthcare professionals and technologists. This extends to health insurance companies as well. So this is where we need to make sure that, well, you know, the people from insurance companies or health finances, they are involved in this discussion, because ultimately, unfortunately, use of AI is not a patient decision. It is a health system decision, right? So health system would look at the bottom line. What is the bottom line? Am I exposed or am I not exposed? And if I am exposed, who can I transfer this risk to, right? And this is where insurance company will come in. So this is a very interesting point, to say the least. At a point where we need to have a convergence with healthcare industry, technology industry, as well as insurance. So I think the scope of this discussion just expanded.
Yeah, that I feel like we are opening the Pandora box bit by bit. It's getting larger, the problem. But I think the issue is really at hand and must be tackled as a society perspective and a stakeholder, multi-country, very, very international, very rich perspective for us to get a collective agreement on this, the same way we got this kind of agreement when you think about vaccines and other things, that they came from a way where the agreement would be easier because we're talking about infectious diseases that would have very high mortality rates, and so it would become easily for a population to understand the risk-benefit ratio to be absolutely evident. And now we move to more nuanced fields more and more, where the risk-benefit may be more difficult to ascertain and everything. And in a way, I think this also will need the building up that Jamal was also mentioning briefly, of continuously monitoring, and there's also a comment here on the chat about this, continuously monitoring what the algorithms actually do. And I come yesterday from Rotterdam on the Odyssey Europe Symposium, where one of the speakers introduced for me a new concept about the perpetual observational study, which actually for AI seems very interesting, and also to shed the light that's needed for us actually doing this kind of decision and thinking about would actually be extremely beneficial in what I see. But before actually passing back to Professor Saleem, if I may, I'd just like to make here a note that we had Dr. Samane leaving, and just a word of appreciation for all discussion we had so far with Dr. Samane. And we also have the high honor of getting Dr. Maaz Shaikh joining us from Abu Dhabi, I suppose. Yeah, very nice to have you here, Dr. Maaz. And here in the panel, we started to touch many topics since from the kickstart video from Dr. Rachel on AI, and we've talked on the direction of bias, on the direction of the need for actually impactful clinic application, on the regulatory issues that we're just talking right now, and the societal implications and how we should think about these tools. And I'll pass the word back to Professor Saleem to close this round. And afterward, I'll give you the floor to explain for you to reflect from your perspective of where you're coming at, how you look at the AI in a broader scenario, and then build on this very fruitful discussion. So, Professor Saleem, what is it that came to your mind? Are you opening the solid floor?
Yeah, so listening to you and Jamal, something came to my mind, and I just thought I should just coin this term. So for vaccine, we have Gavi, right? That provides a vaccine alliance, and then it takes care of everything that we are just talking about in terms of AI and data. So I think there is a potential need for global alliance for AI, GAI. So that's the term that I wanted to coin, and then see if there is an appetite to take this forward.
I think that makes absolute sense, quite frankly, and the term also sounds very interesting. So that this is a good point to pass the word to Dr. Maaz and get an understanding of how AI is being seen from the perspective of the place where you are right now and the work you're doing, and also build up on this discussion on the regulatory. So, Dr. Maaz, thank you so much. I give you the floor.
Thank you, Dr. Tago, and my apologies for joining in a little late. Zoom and systems don't get along well, I think, so I struggled a little bit, and maybe I also struggled with the time zone, so thank you. My apologies. Well, we've been working very closely here. I work for M42, but anything I say right now is reflective of my own personal opinions as a public health specialist by training, who's been into using digital health and technology to solve some of the, try and address, create use cases of how we can address problems at scale, right? And use that to overcome challenges. And I'll just zoom out a little bit before we go into the components of AI, because I believe that AI, or many of the challenges that technologies that we are dealing with or working on right now, are a means to an end. The challenges of healthcare at clinical level, the challenges at healthcare at population and national and international global levels continue to remain, have been consistent. We've been trying to apply newer and newer methodologies. So if you all zoom out some time ago, maybe 10, 12 years, mobile health was the big thing that everybody thought was a panacea to solve all problems at scale. I worked on a very large trial trying to reduce the cost using mobile app. And it wasn't super intelligent. It was just a very simple app that you could give to healthcare workers. Now with the adoption of technology and technology becoming so much more cheaper, the potential to kind of implement that at scale has become very realistic, or rather, I would say a default. Right? And that's where I think the next frontier of innovation in anything that we say in terms of in healthcare, both at an individual level and as well as at a clinical level as well as a population level, could benefit a lot from the use of AI. Some of the technologies, for example, like teleconsultation and telemedicine that started to pick up, say, in the late 2000s or early 2010s. They were a novelty and a novice then, and but given the way of changes that have happened in the adoption of technology, both from clinician perspective, non-clinical provider perspective, as well as the patients who are now more acceptable to the use of technology as part of everyday life, they make it a lot more easier to then now start to say, can we actually explore AI to make these more efficient? Because the challenges that bogged healthcare 10 years ago in the absence of regular technology are now become important even in the context of newer technology. So now we have teleconsultation. Now can we apply cognitive technologies to teleconsultation to make them better? Or can we use generative AI to kind of support the consumption of information? As information grows, there has been larger and larger, increasingly, I would say increasing volumes and pressures of cognitive overload, information overload on providers, clinicians, and everyone to be able to be up to date with that information, to be able to consume that information in a meaningful way. And therefore, the pressures on the system to be able to disseminate this information outside. So my take on generally AI, because as we say, how can I come from a world where we say, let's do no harm first, right? So how can we actually ensure that we start from a point where we start not repeat our mistakes and don't make it a little worse before we make it a little better ahead? So in that context, how can we actually help how can we use these AI technologies, cognitive solutions, and even far lesser evolved technologies, but at a more higher level of adoption or acceptability of use in regular practice, to consume the current science, the current evidence, this thing, and put it back and get it into practice? And therefore, some of those areas, like, for example, being able to access information more faster, there is more data available than it could be earlier, was available earlier, but can it be consumed in a way that was any better than before? Can we use cognitive technologies? Can we use generative AI to apply to those problems, which are far more separated from the ability to make decisions, but more directed towards the point of saying, can we help providers consume this information so that they can make decisions better? I am working on that piece of the track.
Thank you very much, Dr. Maaz. And you opened this even a bit more, because we were focusing a lot on the clinical implication, the regulatory, and now we have this new topic also on the table on how do you make workflow processes that we have been automating more agile at the point of care, and taking the burden away from the clinical people. And I think that is very relevant, because I don't know if it was who said this in the meeting before, but someone said that EHRs, every clinician would feel the EHR as a pain, even though all the benefits that it created us. So I think that this is a very, very relevant insight, because as we wish that adoption of these new technologies gets very much the traction of all the clinicians and stakeholders on the line, I believe that going head on clinical side, of course, we could have tremendous impact. but we're also talking about this very nuanced risk-benefit ratios that we've been discussing so far. And there is this whole other spectrum of things that you can potentially solve, and even the AI may be there and people aren't even aware if we're talking about the automation and the information retrieval and the summarizing, etc., of taking away administrative burden from the clinician. And maybe that is not such a hot topic when we think on the huge, hyped approaches of making the AI agent that replace the clinician eventually. But you have this more grounded and a background. I heard this, I also learned this word very recently, a headless approach where the AI can be embedded on the systems and actually doing meaningful work that doesn't translate into, interaction. It's just there having some impact on the way the workflow, maximizing the way the workflow is occurring, and not actually interacting directly or deciding directly at the point of care. And now that you brought this one, I think it would be great to do a round again, looking at how actually AI in this more operational side of things can be of a benefit. And also, how do you see that relates to the problems we discussed so far with the ethical and policy implications, the data accessibility, all those fields? How do you see that happening on building on top of this direction of more operational side of AI on the EHRs and on the healthcare system as a whole? So we were circling on the square order. Now the square order changed. So I will pass maybe to Professor Saleem, just to have some rule of following the order of the little squares, if you are available. And then we also hear Dr. Jamal, and then Dr. Maaz again. So Professor, please.
Yeah, so this is interesting extension of our current discussion. So so in terms of policy, right? We got to make sure that we have enabling policies in respective regions and countries to enable the promotion of AI. And so that is the building block that we need to have first in place. And once we do that, then it becomes very easy for us to have to extend this into our operations. Because if we do it other way around, then we always struggle. We always face challenges in terms of approvals, permissions, and all that stuff, right? So in my experience, my suggestion is that we go with top to bottom approach in this, not the other way around. Usually, we should have approach both ways, so that top to bottom, bottoms up, and then top to down. But in this case, I would strongly suggest that we create an environment where we have enabling policies for AI to flourish. Because if that is not the case, we always will struggle. And I've seen that. I've seen that in Africa, countries in Africa. I've seen this in countries in Asia. So it is so very important for us to have that. And, unfortunately, in the public sector, as I said earlier, at times you don't see that capacity. So it is our job, it is our mandate, or it should be our mandate to build that capacity there. Because, if we don't do that, then we will never be able to achieve what we really dream to achieve and what we want to achieve. So it is very important for us to ensure that we build that capacity in the public sector, because that is where we are going to make our lives easy. And that is where we are going to make sure that whatever we do has an impact, and it is a lasting impact. It is not a short-term impact, because I have resources as a health system. I can do certain things within my health system, but what happens beyond that health system? This is where we need to have that public sector policy level enabling environment when it comes to AI, when it comes to data, when it comes to everything else in terms of innovation. as Jamal had said earlier, that we need to have environment where we can have innovation that they flourish. So the only way that we can do that is that we have that environment. And I can tell you for sure that there's no capacity there. It is on us that we need to provide that capacity. We need to do that hand-holding. And it is not, we are doing this charity. This is in our benefit. This is to our benefit. If we do that right now, it is our investment in our future.
Thank you. Thank you so much, Professor Saleem. I get inspired to hear the approach and the energy that you put in this regard. And I think that I also agree with what you say. I think that even taking that approach and tackling operational problems first will probably make, the evolution, the curve of evolution go smoother as we tackle this. And if we take this approach that you suggest with so many perspectives of different countries and regulations and regimes, that sounds really that it should become part of our mission as a collective. That's for sure. So, what's your take, also, Jamal, on this?
Thanks, Tiago. Nothing controversial on this round. So I want to. We've been talking a lot about the different bottlenecks in being able to build systems that integrate AI into clinical practice, and Professor Saleem has given us the sort of big picture, public sector, private sector collaboration and how that tackles bottleneck. I want to talk about a different bottleneck on a more granular level, which is basically the end user, the physicians and the patients who will be using these systems. Now, as everyone here knows, healthcare workers are very resistant to change, especially if that change is perceived as something that threatens their autonomy. And there's no benefit to beating around the bush on this one. The definition of autonomy, as we move to more and more intelligent systems and integrate them into clinical practice, is going to have to change. Because at the moment, as a physician, you have full autonomy over the options that you offer your patient based on your knowledge, based on your experience, based on what you know about your patient and their illness. As things change, you might get a recommendation from an algorithm that you don't really understand how or why this is the treatment course recommended. And I'm not going to talk about liability again here because we've addressed that, but but the issue really is how do we convince physicians to adopt systems that might threaten their autonomy? And this is not a perfect solution, but it is one possible solution. And I'd like to hear everyone's thoughts on what other solutions might be. The very obvious one is to engage physicians and patients in developing AI systems from the design stage onwards. To do that, we have to sort of bridge the gap, the language gap between AI developers and clinicians. And I think Dr. Samane early on talked about how the most important thing is not just getting access to the data and not just doing the machine learning part of things, but understanding really what the issues are, what the pain points are, and so on. And so training physicians in AI competencies is really, really important. I know the Canadian I can't remember what the association is called, but the association that produces the CanMeds competencies have recently added digital competencies to their list of competencies. At RCSI, where I work, we've introduced an AI in healthcare module to year 3 students that aims basically at giving them big picture, understanding ethics, being able to evaluate AI in healthcare solutions, And the more interested ones, we'll give them some training in no-code and low-code platforms, just to try and build their competencies in this sphere. And I think that's a very important barrier to overcome if we are to get AI to actually have an impact on clinical practice. Thanks.
I think that's a very, very insightful sharing, Jamal, and I totally also resonate with that. I'm one of the things I'm trying to do is advocate for a new profile of people that maybe I would call them the clinician data scientist, that could fill that exact gap. In my view, we need to make the intersection of fields bigger and bigger and bigger. And we have a hand from Lisbeth Siderius. I'm not sure if I'm pronouncing the name correctly. I'm sorry if that's not the case. So it would be great that if you could briefly present yourself and what is that you'd like to ask or share. Please go ahead.
Thank you. I'm Lisbeth Siderius from the Netherlands. I'm a pediatrician and also patient representative specifically for rare diseases. And I will tell you about a case, because last week I was at the meeting in Geneva, and I want to think about AI versus data first, what we are propagating. So a case is, I work in a primary care setting. Parents come with a child. I write down in an electronic record what they say. And they say, oh, they are afraid. This child is now almost 4 years old. He cannot go to school. And we think maybe he has autism. I write this down. That parents tell this to me. Nowhere in the chart says, I think the child has autism. I just write it down. Then the parent goes and look into the file. He asks our manager to see his registration, and he wants and complains that I have written the word autism in the chart, but it was only his own words. And then he wanted me to take out the word autism. And I could imagine why, because he doesn't want his child to have the stigma of 4-year-old autism word in his chart. So that is what I think we have to realize, that why I am personally a bit afraid of AI, that you see words, but you do not see the status of the word. He was never diagnosed as autism child. But if you would look at all electronic records, you may find things like this. So I think that is why I really like structured data. Structured data in like we are emphasizing, we want to do in with electronic records and codings and interoperable data. Structured. Who makes the diagnosis? Why does this word come into the chart? So in my case, I didn't like it. I had written exactly what I should write because the parent had told me that. I had to take out something which I should have put in my case. But I could also understand the parent. So this is for the discussion and a sort of ethical and political thing, but more ethical. And AI people should realize these sort of problems.
Dr. Lisbeth, thank you so much for this sharing. I think that first person sharing of the difficulties and the cases puts everything into a very concrete perspective. And this fits very well with what we've been discussing about the bias. And now you bring in additional sources of bias that the data may have and in the context. And so maybe I will, Professor Saleem, would you like to comment on this? And we do a round of discussion about this topic. I think that the topics keep flourishing, even if we don't follow exactly the plan. We're getting in a very much richer place. At least that's what I'm feeling. So I would like that we take this contribution of Dr. Lisbeth and build up on this. Thank you so much. Professor Saleem, what's your What's your perspective on this?
Yeah, so I would just extend the comment that Jamal had made earlier, and that is the need for AI education in medicine. So, and then I heard him say that there was a module that was added to third-year students as well. So I think that is all good, but there is another way to actually address that, because our future is AI. Future is data and AI, right? Whether we agree, we like it, we don't like it, but that is what it is, right? So how can we make sure that we are serving to the population that we are supposed to serve? So that is our doctors, current doctors and future doctors, right? So one way to do that, in my opinion, is making it as a part of continuing medical education. So when you go for your recertification, every 3 years, every 5 years, whatever the case may be, you may have a module in AI that you have to actually know what is AI, what it can do, what it is doing, and all that, so current trends. And your competency is measured based on that, so that, you know, then it is not just one module that was in your third year that you read, you studied, and then there's no continuing education behind it. Because, you know, with the speed that technology is moving, we need to have this every year rather than 3 years. But, you know, I would settle with 3 years if it is CME for 3 years. So that is another way to actually see that.
Thank you, Professor. I also see Dr. Maaz with the hand raised, so please go ahead.
Thank you, Dr. Tiago. I had something else to say, but I think Dr. Liston's remark completely changed my mind. I wanted to tie in what Dr. Jamal said, Dr. Saleem mentioned, because they too tie in really well. In order to achieve scale and in order to prepare ourselves for the future, we need to do something that keeps the primary user, which is the healthcare providers, motivated and engaged. And while training is one of the parts, Dr. Jamal really raised a very important topic of how do we keep them satisfied by not taking away their autonomy. Spoke about autonomy. And thank you, Dr. Liston, that the example that you mentioned so very well seeps into that perfect spot where you're saying, you know, how do we kind of, engage at a point where we are making it safer even before we go to clinical decision making, at the point of, you know, making information reasoning more safer, so that downstream, as this information or data is used to evolve the AI models and the solutions to go further into decision making, are better curated. So that kind of goes back to the point of saying, how are we kind of using this to make doctors more autonomous in their decision making, while kind of making sure that, you know, that decision making is being made on data that's safe and in an experience that's satisfying to both the provider as well as the patient.
Thank you very much, Dr. Mazit. I think these contributions are very relevant, and they also raise the point that AI can be a helper, have a protective role for the physicians in these cases, if we think about it as a tool that may help understand, may help bring the context of the decisions clearer once we have to bind into putting a diagnosis that we may face this kind of challenges Dr. Elizabeth meant of the parents wanting it to be outside of the chart. So maybe we can also look at AI here as an agent that can help us in that regard of helping us become defendant, as Dr. Maaz said, helping see if we have the data that actually supports our reasoning being well documented, strong enough for the case to be, you know, very clear to defend on this rationale. I understand that the issue at hand comes. Maybe we can use the term that comes from, I would say, pretty much US side of medicine, of the defensive medicine, that will also face more and more to be a challenge. And maybe AI can also take here a place and help in the situations like Dr. Lisbeth meant. I will pass the word again to Dr. Lisbeth and also then Dr. Jamal for his insight as well. So please, Dr. Lisbeth.
This case was just about how you can look into charts, other people can look into charts without knowing the whole perspective. So if the computer would look into the chart without knowing the whole perspective, that I am sort of afraid of. If we do not define exactly what data, how the data are structured, so that's why I'm very fond of data first. It's not, I did not make a diagnosis. I know very well, you don't have, none of you AI people have to help me to diagnose autism. I know very well. It's very easy. And we do it all the world a bit the same. So do not, we know, as doctors, we know very well, if you have this, if you see a very pale child, if you see a yellow child, I know what to do. In one case, I do bilirubin, in the other case, I do hemoglobin. Very simple. But these data have to be structured. A yellow child, do bilirubin. And that we know. But the data we put into our child should be structured this way. And that can be done with the international codings like LOINC and ACD. And we can transport it with FHIR. And then the structure is there. With this structure, you can do AI, not without this structure. And I'm very now strong for this because it will be dangerous. As sort of now I mean, you can educate doctors on AI, but you first have to educate them on data.
Thank you for the contribution. I think the guardrails around data make a lot of sense indeed. And maybe Dr. Jamal, you want to extend on these comments?
Yeah, sure. Thanks. I think Dr. Elizabeth's point is very pertinent. Again, to the autonomy discussion. The idea, and to make this work is to see how we can empower physicians with AI rather than take away their autonomy or take away things that they're very good at doing. And the risk of over-reliance comes to mind as well, because Dr. Elizabeth has a lot of experience in pediatrics, and as she said, for her, it's very simple to make this diagnosis, very simple to triage patients and address their needs. But for the upcoming generation of physicians, it won't be so easy, and it won't be so clear, especially if a lot of the clinical reasoning is taken over by AI systems. Then we'll find ourselves at risk of having the same thing that occurred with advanced imaging, and the way that impacted people's clinical reasoning abilities. Then it can become even worse. So I totally agree with your point, Dr. Elizabeth, that yes, we should educate them about AI. Yes, we should educate them about data, but we should also double down on educating them about, having solid clinical judgment. Now, when, it all depends really on how we apply AI in the clinic, and that, I guess, is the central question. What is the approach we take? There's a really great book called Power and Prediction. And it talks about the concept of decoupling, prediction from judgment. So with our clinical reasoning, we're able to predict which child has autism and which child, doesn't have autism or has a different, has a different condition on the spectrum, for example. But then it goes down to the judgment of the physician and their understanding of the context, right, and understanding of the parents and the situation overall. to take the right action that's right for the child, or right for the patient. So, you know, we don't necessarily have to take away people's autonomy and decision making. We can just provide them with the predictions. If we, you know, if we apply it as a predictive machine, we can provide them with the predictions and then let them use their judgment. And I feel like that might be a happy medium, right, where you get data-driven insights, but you still have, you know, the human in the loop making the judgment. Now, that will be good enough for now. That will be good enough for the level of, you know, AI development that we have at the moment. But then the question that always comes to my mind is, you know, when we arrive at superintelligence, or not necessarily superintelligence in every domain, but, you know, if in my field or your field, AI, you know, algorithms have surpassed human intelligence, should we then continue to rely on human intelligence in these fields when it might not be as safe as applying an AI solution? You know, it's a very difficult, you know, these are very difficult questions to answer. I'm sorry that I'm giving more questions than answers, really, but it's, you know, it is that is the state that we're in. The future is not very clear. But, you know, we have, like, at the moment, we have the power to contribute to designing it, right? We just have to see, like, what, you know, what values we want to design it based on.
Dr. Jamal, that makes a lot of sense, and I think this insight that come from different medical specialties here are sitting on the table. They really enrich the spectrum of things. We are getting close to our time for this session, so we still have 7 minutes before I pass back to Sophia for wrapping up. And I will just launch a final thing on the table before giving the floor to each of the panelists. And Dr. Elizabeth will also be very welcome that you had your hand raised to actually also contribute, which is looking at large language models and all the expectation that has been built around them, and looking at all these nuances and complications that we've been talking here about, the complexity of healthcare data, how we are not really there yet regarding to data standardization, properly capturing the context of the data to actually do any proper machine reasoning with safety and efficacy that we need. So this is a bit provocative, but do you think it is in this LLM era that we will be able to actually have a clinical impact with the current tools that we have and that are getting this huge use on so many fields, or do you think we're not there yet? And is it going to be another set of tools, or how do you see the future from where we are now that LLMs are such a mainstream thing, and almost no one knew about LLMs like 1 year ago? Yeah. So maybe I'll do this final round, and so then we close off with this interrogation mark, and maybe with a follow-up session. But starting with Dr. Maaz, what's your take quickly?
So, Dr. Thiago, and I would say technology is going to evolve. It's never going to get perfect. If you never knew about this technology 6 months ago or a year ago, it was there. It wasn't usable, or it wasn't viable to kind of use that technology. So things will change, but there are certain parts of the technology that are still very useful. So if you identify a sweet spot of the technology capability and the use cases within healthcare that it can power in a accurate and an acceptable manner. So there's an optimization between those two variables in performance, accuracy, and acceptability. Then we may be able to kind of leverage some of the current technology that we have to create impact in today's time, while we wait for technology to evolve further, that it can be applied verified, validated for other more complex use cases as we go. I'm very positive on that.
Great to hear that from you, Dr. Maaz. Thank you. Professor Saleem.
Yeah, thank you. So, in my opinion, LLMs tend to hallucinate. So we got to be very careful. We got to be very careful when we are using that for patient and making decisions for patients, because that is a high risk proposition. I'm not saying that we should not be doing that, but we need to use it with caution, a lot of caution. And there should be some sort of intermediary layer where we can validate that information. So for example, rather than using LLM generally available like ChatGPT or something else, hospitals, health systems, they have designed their own LLM. So if you look at, I believe it is University of Michigan, they have their own LLM. So now you can say with certainty that, well, this data is coming from reliable source. So it is coming from their EHR. And then Jamal, to your point, that now they are actually using their EHR to predict a patient outcome based on LLM and based on AI. So that is what we should be doing. And then, I strongly believe that we should have small islands of success. And then ultimately it will create a large island, right? So if we go for a large island, that would be very difficult. So low-hanging fruits, small successes, and let's build on that, right? So, but reliability is really important. We need to make sure data is validated before it is used for patient care at all. So there's no compromise there.
Thank you, Professor Saleem. Dr. Jamal.
Thanks, Liam. So I really agree with Dr. Saleem's point about the importance of reliability. With the MedGemini paper, I can't wait to get my hand on MedGemini to see how accurate it is. But in terms of experiential data that's available to us, it's still not clear whether generalist models like ChatGPT will outperform models trained on specialized data. So far, what it looks like is, if you exclude MedGemini, because we still haven't really seen it in practice, we've only seen the paper. And if you exclude MedGemini from this, then it seems that with the right prompt engineering, ChatGPT can actually outperform PubMed GPT and other GPTs that are trained exclusively on medical data, and they're only going to get better. So I'm not too concerned about the increase in reliability with time, right? That is something that I feel we'll definitely see. And like you said, Prof. Saleem, find the low-hanging fruit, start demonstrating success, start tackling people's pain points, and that's how you start getting more and more acceptance of AI in clinical practice. For example, start by tackling the electronic health record, the bane of everybody's existence. That's something that could definitely be tackled with LLMs. That's it.
Thank you very much, Dr. Jamal. I think we had a great discussion here. We touched a huge number of topics, but despite the number, I think we delved really deep in very focal, crucial points. So I believe this was a very enriching session, at least for me. I learned a lot by hearing your insights, and I think that this will actually make even the point, after this discussion, we get the point even stronger, that this data first, AI later, a way to frame things actually makes a lot of sense. And it's probably a very sound, very promising way to move securely towards all these potential results. but having in consideration also this very collaborative approach that we need to create these lessons, this proper education of all the fields, the greater intersection of all the fields, the global perspective from the learnings of so many regions around the world on these fields, starting with the healthcare data and the access and the safety, and then the models, and then the rolling of models and validating the models. An holistic approach with a very wide global community of thinkers. It looks like it's totally a road ahead of us after this very interesting and enlightening session. So thank you so much for sharing these thoughts, and also Dr. Elizabeth for the use case, which was very also enriching to the discussion. And so I pass to Sophia to close the session in time.
Just in time. Thank you. Thank you so much, Professor Tiago. And thank you so much for all of you. And it was truly a very enlightening discussion throughout this morning. Truly, it is we have a road ahead, and I hope we can count on all of you to come with us on this road. We will be giving you feedback on how we are going to proceed on this movement. Data first, AI later. We are hoping to build a true movement that can help structure this need for solid and healthy data to construct true and enriching public policies all around the world. And I hope that this small conversation has also made us all in a bridge, put us all in a bridge for our proximal event in November. We are holding an event in Lisbon regarding real world evidence for the real world. So I hope I can count on all of you to be with us in November here. And thank you to all of the people who have joined us online and who have been following us. Thank you so much, everyone. And I hope you had as much fun as I did. Thank you. Bye-bye.
Thank you very much.
Thank you.
That's great.
Thank you so much. Take care.
Take
all.
care. Thank you.
Thank you.
Bye-bye.